Our first talk of this session will be presented by Dr. David LILLICRAP from Kingston General Hospital. His talk is entitled Hemophilia Gene Therapies, the Current State of Affairs. So please welcome Dr. LILLICRAP.
Okay, thank you very much indeed for the introduction, and thank you for asking me to talk about this subject. These are my disclosures. So I'm going to begin with this slide here, which, as you can see, is the first page of a review that I and my colleague Christine Huff wrote back in 2005. And part of the reason that I'm delighted to be given the opportunity to speak this afternoon is that for some of you, you know I've been standing on podia for the last 30 years saying this is going to happen. And I can actually now tell you that it is going to happen. I mean, it is beginning to happen. So any credibility that I previously had, which is probably very small, is maybe marginally better. So the first message is that this journey has taken several decades to reach where we are now. And on this slide here, you see some of the historical progress. So the original cloning of the genes was back in the early to mid-1980s. The first gene therapy trial was actually carried out in 1993 in China, where some Chinese investigators removed some skin cells from an individual, did some genetic manipulation outside of the body, re-implanted those cells, and nothing happened, fortunately. I think you could say that was actually potentially a dangerous thing, but nothing happened. There then followed 15 years of investigation in some small phase 1-2 studies involving sort of 10 to 15 patients with 3 different types of vectors: adenovirus, not adeno-associated virus, we'll return to that, retroviruses, and eventually AAV, or adeno-associated viruses. And these studies were okay, nothing bad happened, but nothing very spectacular happened. And then in 2011, the first successful gene therapy study occurred, carried out by some investigators at University College London, Amit Nathwani's group, and a group in the US at St. Jude Hospital. So let's begin by just saying, what is gene therapy? So we use a manipulated viral vector, and this slide here hopefully will reassure you that these are not viruses that are being infused into patients. The virus that we borrow from is called adeno-associated virus, or AAV, and AAV has a genome which is encapsulated in just one chromosome. Humans have 46 chromosomes and we have 20,000 genes. This virus has one chromosome and it has 2 genes. They're referred to as rep and cap. At the beginning, at the top here, you see a yellow and a gray bar. Those are the 2 genes of this virus. When we make a delivery system, a vector for hemophilia, we remove those genes from the viral genome and we insert a transgene, which is either factor 8 or factor 9, and we, in red, give that gene a regulatory element which makes the gene make the protein. We leave 6% of the original viral genome, those bits at the end of the genome, which are required to package that into something you'll see in just a moment. So these are not viruses. These are viral vectors, and that's a big and important message for you to sort of grasp. So you then take this genome and you package it into a protein coat, or a so-called capsid, shown at the bottom there, in this icosahedral shape, and that's infused into a peripheral vein. You'll hear from people who've done this here in Canada. This takes maybe half an hour maximum. You may have to stay in hospital for 1 day, but this is not a very complicated process to deliver the vector into the body. Now these capsids, or the protein coats, which are in the various different colors here, deliver the vector into different tissues, and you can see the ones that I've outlined in the red shapes. these all have a tendency to go to the liver, which is where we want these to go. So you deliver into the venous system, and these particles are smart enough to find their way to liver cells in your liver and then enter the liver. And most of what I'm going to discuss is about this so-called serotype AAV5, which, as you can see, has a predominance of getting to liver cells. Now, some of the vector will spill over into other tissues, but the regulatory sequence that I had referred to on the previous slide only allows the vector to express within the liver cells and not other cells in the body. Now, when the vector gets into the cell, if you look at the top left of this diagram, you see the vector is uptaken into the cell. It then goes through a system in the cytoplasm and then into the nucleus, where it loses its capsid, it loses the protective layer, and then it makes a second strand of nucleic acid, and it stays in the nucleus making messenger RNA, which then gets converted, translated into protein, and then at the top right, it gets secreted out into the bloodstream. Most of this is really a bit of a black box. We don't understand very much about how this happens, and there are details here that I'll get back to later in my talk, which are important for you to know about. But honestly, many of the details here are still fairly vague, I would say. So in the next 20 minutes or so, I'm going to discuss, can we predict how likely you are to be eligible for gene therapy? Will you get a good clinical response? Can we predict your factor level? How long will this work? Are you likely to develop complications? And will gene therapy cause cancer? So I'm going to briefly touch on each of these questions in the next 20 minutes. So the first question is, can you be considered for gene therapy? The most important thing that you're going to be tested for is to ask whether you've seen AAV infection previously. So has your body developed an immune response to AAV? And what you can see here on the left-hand side are some global results for different types of AAV, AAV2, 5, 8, and 10. And you can see the prevalence of seropositivity. So individuals who have seen the virus before and they developed an immune response, which means you cannot get these vectors. Or at least simplistically, that's the case. I'll come back to something at the bottom of the slide in just a second. But you can see that for AAV5, about 35% of individuals in the population are going to have problems accepting the vector. The vector won't get to the liver because it's attacked by antibodies. On the right-hand side, you see there's some variability between different countries, and I won't go into that any further. By the way, this is a population of over 500 hemophilia patients in 9 different countries. Now, the thing at the bottom here says that one of the trials, the CSL trial, which I think is going to be discussed early on Sunday morning here, you can have low levels of antibodies against that vector and still get good results. So there is, as usual, there are exceptions to every biological rule, and that's an exception to this particular rule. Now, the next question is, will I have a good clinical response? And here I'm using information that's derived from the phase 3 factor VIII gene therapy study, which I'll refer to in subsequent slides. So basically here, let's begin on the left-hand side of this slide. And in each of these instances, we're talking about the annualized bleed rates. And you can see that 49.3% of these patients had an ABR before gene therapy of greater than 0. So they bled more than once per year. And after the gene therapy, they didn't bleed at all. So their ABRs were greater than 0 before and 0 afterwards. The next quadrant, going clockwise, 26.1%, had good responses before. They were on prophylaxis, regular factor VIII prophylaxis. So they had an ABR of 0 before, and that continued afterwards. So this is now 75% of patients who benefited. Their ABRs following gene therapy are 0. The next quadrant, 14.9%, the ABRs were greater than 0 before, and they declined afterwards, but they didn't decline to 0. And then the last quadrant, down at 9.7%, had ABRs of 0 before and afterwards, with a slight increase. And these were small numbers of individuals who had ABRs of usually around about 5 or 6. Not large, but they were higher after the gene therapy than before. So this slide and the next slide now illustrates something. Many of you have seen these slides, I suspect. They're the factor VIII levels in the phase 3 BioMarin study, showing you here, going out to 52 weeks in 132 individuals with severe hemophilia A, treated with 1 infusion of vector. And you can see in these box and whisker plots, so going from 25 to 75% quartiles, the factor VIII levels beginning to increase at 4 weeks, peaking between 24 and 30 weeks, and then gradually beginning to decline a little bit out to 52 weeks. You can also see that if you look at the tips of these whiskers, some people got much higher levels and some people got no levels. So there was a significant amount of variability of these levels, and at 1 year, the mean and the medians were, the mean was 42% and the medians were 22% factor VIII. A small number of these patients, 17 of them, were followed for 2 years, and you can see this drop-off of the levels from 1 year to 2 years is more significant. So the levels of factor VIII, which at around 30 weeks were quite high, are beginning to drop off at 2 years. And some of these patients now have been followed out to 5 years. They have persistent factor VIII levels, but the factor VIII levels are lower, somewhere in the region of about 15%. So they are not bleeding, but their levels of factor VIII have declined from the peak levels that were there at about 6 months. What did this mean about the annualized bleed rates? So you can see on the left-hand side of this slide, red is the median, blue are the means. They went from the baseline ABRs of 2.8, 4.8 down to vanishingly small levels, practically no bleeds. And then on the right-hand side of the slide, the number of annualized infusions of factor VIII. Remember, these patients were on regular factor VIII prophylaxis, so they had over 100 infusions at baseline, prophylactic infusions. And then after week 4 of the gene therapy, when it starts to work, their infusions went down to almost nothing. So there is a huge clinical benefit that you can see here in terms of their ABRs being excellent and their infusion rate vanishingly small, very, very infrequent infusions required. Now we're going to switch to factor IX, because one of the messages I need to convey to you, and I'll do this on a slide subsequently, is that factor VIII and factor IX gene therapy are not created equal. And so hopefully this will become apparent when you look at this slide here. So this is the HOPE-B study, a phase 3 study involving 50 individuals. And you see here levels going out to 18 months. So on the right-hand side of the slide, we're at M18, 18 months. The one-stage factor IX levels are on the vertical axis. And what you see is that, again, this begins to work at about week 3 to week 4, and the levels at 6 months were 39%, at 12 months were 39%, and at 18 months were 34%. You do not see the drop-off with factor IX that you see with factor VIII. The levels going out to at least 18 months appear to be very stable in contrast to what we saw with factor VIII. And the variability is pretty decent. It isn't ideal. There's still some patients that are outliers, but the predictability of these responses look to be, in these 51 patients, much better than we were seeing with factor VIII. Now, I think I have just one slide about toxicity, and that's shown here. So many of you will be aware, this therapy is to the liver, and the most frequent and potentially serious issue here is that of liver toxicity. And we measure that in the blood by measuring this enzyme that comes from liver cells when they are not well or when they die. And this enzyme is called alanine aminotransferase, or ALT. And when that gets elevated, it's telling us that the liver is being damaged. You'll see in just a moment that the ALT elevations were quite high in factor VIII. In factor IX, not so high. These patients were treated with corticosteroids. The duration of those steroids, usually prednisone or prednisolone, was anywhere usually from 1 to 8 months, sometimes actually even a little longer than that. And because of that, many patients experience complications from steroid use. And we're going to hear from 2 patients today, and I think one of those patients at least is going to tell us about the steroid issues that that individual experienced. And sometimes the ALT values didn't even respond to steroids, and so other immunosuppressive drugs had to be used. So this is an issue, and unfortunately, we don't really understand why it's happening. So we need to understand more about why this liver toxicity occurs. So anyway, here in summary is why I wanted to emphasize this thing about the results with hemophilia gene therapy are different. So on the left-hand side in red, you see the factor IX information, and on the right-hand side in blue, you see factor VIII. So let's begin with predictability. I think we can say that factor IX, the predictability of the outcomes, is fairly good, actually pretty good, whereas with factor VIII, the predictability is, you can't say for individuals whether you're going to end up as being the very small numbers who get no response to someone who may have 200% factor VIII. The variability is small with factor IX. I think I showed you that on a graph, whereas the variability with factor VIII is large. So those 2 things are important things which at the moment when we sit down with individual patients, we can't tell you with confidence about where you're going to end up in that spectrum, particularly with factor VIII, but more so with factor IX, we can give you a better idea. The liver toxicity is less with factor IX vectors, about 20%, whereas with factor VIII it was as high as 80%. So significant, unfortunately, worse liver outcomes. And then the duration of benefit, some factor IX cases have now been followed beyond 10 years with stable expression, and with factor VIII we're out to 5 years, and we don't really know beyond that. So you can draw your own conclusions when you look at this, but you cannot say at the moment that these are equal, that factor VIII is more problematic for a bunch of reasons which we could get into if we have time later. So in the last part of the talk, I just want to say a few words about what happens when the vector gets into these liver cells. So it's injected, it finds its way to the liver through the blood, it gets into liver cells, and then it exists either, as you can see at the top here, as not getting into the chromosomes of the human, or it can be integrated into the chromosomal DNA within the liver cells. So the vector gets into the nucleus. I've outlined there this thing called vector persistence. It stays there long term. And that persistence is either floating free within the nucleus in these so-called episomes, or getting into the chromosomes in our normal genome. This in some ways is a little surprising because AAV doesn't have a natural history that makes it integrate. It isn't what we call a retrovirus. Some of you with a biology knowledge will have heard this term. There are some viruses that, as part of their natural history, invade the genome. AAV is not a retrovirus, and in fact, as I said earlier, we're not even injecting the virus, we're injecting particles which have a little bit of the virus left. But here's the issue. So when we talk about AAV vector integration, much less than 1% of the vector particles integrate. But the vector doses we're using are very big. So for those of you that are not mathematically inclined, maybe including me, 10 to the 15 particles has a lot of zeros. I mean, however you look at it, 1% of this is a big number. And so this is the issue, that a very small percentage of the vector gets integrated, but it's still a large number because the input is very big. And the integration is widespread. So what you're looking at here on this complicated picture is a chromosomal array from dogs. So many of you know that we have hemophilia dogs at Queen's University, and we carried out studies on dogs that have been followed for 10 or 12 years. And when we looked in the livers of those dogs, you can see by that dogs have 38 chromosomes, and at the bottom is an X chromosome, and you can see each of those chromosomes has these blue marks on it, and each of those blue marks is an integration of vector sequences. So they're everywhere. They're distributed throughout the dog genome, and there's no reason to believe that wouldn't be the case. In fact, we know it is in non-human primates, and it is in humans as well. So what does that mean? I mean, this happens. We know it happens. It's not a secret. So we know from long-term animal studies, so 17 hemophilia dogs now have been treated in Canada and in the US with different serotypes of AAV and have been followed for up to 12 years. What I can tell you is that those dogs have all undergone extensive autopsy examinations at the end of their lives, and there has been no evidence whatsoever in detailed gross analysis and histopathology of any liver tumors and no other tumors. So there's no evidence in these long-standing experiments in large animal models of tumorigenic phenomena with gene therapy. However, cancer is common. Everyone knows people who've had cancer. This is a common disease. There are hundreds of patients who've now had hemophilia gene therapy, and so there have been 4 cases of cancer in patients who've been treated with hemophilia gene therapy. 2 patients who received factor VIII gene therapy, and 2 patients who received factor IX gene therapy, and they're listed on this slide here. So a liver cancer, a salivary gland cancer, a type of leukemia, B-cell acute lymphoblastic leukemia, and a cancer of the tonsils. Each of those instances were extensively investigated by genetic analysis, which takes a long time, is complicated, and in every instance, there was definitive evidence that the vector sequences were not involved in the cancers. They did not drive those cancers despite being integrated into the genome. So cancer will occur in patients who have hemophilia gene therapy, but that's because cancer is common, and at least for the moment, each one of these instances will be very carefully investigated to ensure that the vector, the gene therapy, has not been causally related to the cancers. So this is my last slide. So in summary, what I've shown you is that first of all, early phase gene therapy studies, phase 1-2 studies, which are small, 10 to 20 patients, tell us things about efficacy and safety of gene therapy. The phase 3 studies, and I've shown you data from 2 of those, one in hemophilia A, one in hemophilia B, usually have between 50 and 130, 150 patients. They're big, and they need to mature over 2 years. So this is not simple or quick. We can't do that. We have to be careful. The knowledge and the management of hepatotoxicity needs to improve. I emphasize that. There are immune obstacles, pre-existing antibodies, and many of you know that if you receive gene therapy, at least for the moment, you cannot be retreated. So at the moment, this is a one chance, and then whatever happens, happens. There may be ways of getting around this, but at least for the next 5 years or so, that isn't going to happen. So at the moment, when you get gene therapy, you will develop high levels of antibody against the vector, which prevent readministration. And then the last bullet is that the biological knowledge of gene therapy and gene expression is still very limited, and we need to know much more about this before we proceed. But none of these considerations should inhibit the licensing of current gene therapy products. And 2 of those have been licensed. You're aware of that. In August of last year, the factor VIII gene therapy was conditionally approved in Europe.
It's the rogue phone, I'm sorry.
Sing along to the music. And then in November of last year, Hemgenix, the factor IX gene therapy, was approved by the FDA. And so with that, I think I'm going to finish. Thanks for your attention this afternoon.